Good afternoon, everyone. Thank you so much for joining us today on this very important topic, which is about the long-term impacts of preeclampsia. We're so grateful for you being here, and we know that there's a lot of preeclampsia survivors in this room today, so we're very thankful that you all are here to learn a little bit more on this topic. I'd like to first of all recognize our partners, the Association of Black Cardiologists and Women Heart, and our sponsor, Abbott Diagnostic, for being such wonderful education partners in this work. They believe, just like we do, that every preeclampsia survivor needs to have the tools that she can have at hand for good heart health. So we're very excited to get to give this great presentation today. So I wanted to first of all say that we will use the term woman, mom, mother, she throughout, but that we recognize that every patient deserves good care that respects them and includes their representation. So we don't want to leave anyone here with the sort of dire statistics around heart health and preeclampsia, but it's important to know, of course, that if you've had a hypertensive disorder of pregnancy, which can include gestational hypertension, preeclampsia, eclampsia, HELLP syndrome, or any combination thereof, you are at higher risk, 2 times the risk of heart disease, 2 times the risk of stroke, and 4 times the risk of high blood pressure later in life. So if your overall heart health is low, this may not be as impactful, but for someone who may have more than one risk factor, you may have a much higher risk. And as we know, heart disease is really the leading cause of death for women ages 65 and older here in the US. It kills more women than cancer, lung disease, diabetes, almost 400,000 women a year. And so every woman who has had preeclampsia needs to know this information and be proactive about their health. Because what I'd also like you to know is that it's not just about the dire statistics. There is some solutions being found out there. So the number one question that we get from preeclampsia and HELLP syndrome survivors like those on the call is, okay, now what? What do I do? I know I'm at risk. Do I need to talk to my primary care provider? Why did this risk happen? How do I know if I need to have a cardiologist? Am I going to experience this? And so the good news, and hopefully your main takeaway from today's presentation, is that there are some really good steps that you can take for yourself, your family, and your community. One of the ways that the Preeclampsia Foundation really does this work is that we recognize that it's a problem that needs to go beyond obstetricians. Obstetricians in general are fairly aware of this link between pregnancy health and heart health, but a lot of primary care providers and allied healthcare teams or health professionals like doulas and childbirth educators and social workers may not be aware and may not know the steps that they can use to help a patient or a client to do different lifestyle changes and things that may improve their cardiovascular health. So that's why one of the most important things that we do at the Preeclampsia Foundation is go out and speak to groups that care for patients beyond pregnancy. This photo here is from the Broward County, Florida Healthy Start program, where myself and a patient advocate went and did a really cool presentation about preeclampsia and the way that allied health care professionals can support women beyond pregnancy. Now, what about the patient side, your side? You also need tools to help you to manage and understand what's going on. So the Preeclampsia Foundation co-developed in partnership with the patient community, the Society for Maternal Fetal Medicine, and the International Society for the Study of Hypertension in Pregnancy, this really excellent tool called My Health Beyond Pregnancy. You can see the QR code on the screen. You can actually scan that, and it's free to download in English or in Spanish. We're also working on translating it into other languages. But this is kind of a one-stop shop printable download that you can take with you to your doctor or your nurse practitioner or whoever you're kind of seeing for your primary care and talk to them about your birth experience, because they may not be aware of the link between pregnancy health and heart health and may not know that, there are certain tests or things that you might need to have run as a person who's at risk for long-term heart disease or cardiovascular disease. So this tool is out there and available for anyone to use and share. I also want to just do a quick plug to say that one of the great ways that you can get out and get moving is through the Preeclampsia Foundation's Promise Walk for Preeclampsia. We have almost 40 locations this year, so you could scan the QR code on your screen as well to go look at where those locations are and hopefully find either an in-person or a virtual event that you can participate in and get some steps in. May is also Preeclampsia Awareness Month, and it's when our walks actually kick off. And I'm really excited. You guys are getting to hear this first, but our theme for the 2025 May as Preeclampsia Awareness Month is going to be Ask Me About Preeclampsia. And it's going to be a very back to basics campaign where we focus on the fact that we need to talk more about pregnancy health and about the word preeclampsia. So we're really looking forward to getting to participate with all of you all and helping to amplify and get that system out. All right, so now to the crux of the talk today. It's my privilege to get to introduce 4 fantastic speakers for today's event, starting with Dr. Rachel M. Bond, who's a board-certified attending cardiologist and the system director of the Women's Heart Health Program at Dignity Health in Arizona. Her expertise in cardiovascular disease with special interest in women's heart health, prevention, lipid disorders, cardioobstetrics, and autoimmune related heart disease is very well researched and known. She's also a well-known spokesperson for the American Heart Association Go Red for Women campaign and a member of the Association of Black Cardiologists. Her colleague, Dr. Annette Ansong, is a researcher, pediatric cardiologist, and the medical director of outpatient cardiology at Children's National Hospital. She studied at the University of Virginia, followed by medical school at Howard University and pediatric residency at Duke University Medical Center. She's involved regionally and nationally on issues of diversity, equity, and inclusion, and currently co-chairs the Women and Children's Committee for the Association of Black Cardiologists, who are our partners in this. The third speaker is Christian Hunter, who is the Area Systems Director for the American Cardiology and Pulmonology for Abbott Diagnostics. He brings a very long career in global health, clinical research, education, and basic science, and he's going to talk to us a little bit about some of those global perspectives on and the things that he's seen at the bedside as a practicing cardiologist. And finally, Selena Gore is the Chief Executive Officer of Women Heart, who's a longstanding partner of the foundation and whose mission is to improve the lives of women with or at risk of heart disease while also fighting for equity and health. Selena has devoted her entire career to healthcare advocacy, including developing health and social programs for multinational companies and global agencies like the UN Population Fund and UNICEF. And we have a very warm relationship with Women Heart because many of the patient community that passes through Preeclampsia Foundation goes on to participate and get involved with Women Heart and continue as an advocate for women's heart health. All that being said, I'm now going to turn the presentation over to Dr. Bond.
Thank you so much, Lainey, and thank you all for taking some time out of your busy schedule to speak, or at least hear us speak. So Lainey went through a nice overview of what preeclampsia is. I'm just going to go in a little bit more detail and really bring the perspective for myself as a cardiologist, particularly one who focuses on women's cardiovascular health. And I think it's important to first actually define what preeclampsia is. What I often notice in my patient population when I'm seeing them is that they're not always 100% certain if they've had preeclampsia. And it's important to realize that preeclampsia is defined as a hypertensive disorder of pregnancy, and there's a spectrum of that. There are conditions that may not necessarily affect the organs where the blood pressure is elevated and it could be brought on by pregnancy. But when you think about preeclampsia, it is oftentimes occurring after that 20-week gestational period, where you have on 2 occasions, at least 4 hours apart, a blood pressure greater than 140 over 90 millimeters of mercury. And there could be protein or evidence of organ dysfunction. And I think that this is the most important aspect, that not every patient requires protein to have the definition of preeclampsia in their urine in particular. As Lainey mentioned, preeclampsia is affecting about 5 to 8% of all pregnancies in the United States. including some patients who actually don't have any known risk factors for it. And common risk factors that we always think about is family history. So knowing your family history is key, particularly your mother's history while she was pregnant with yourself, but also there are many people that have it for no rhyme or reason. And one risk factor is your first pregnancy. That could be a risk factor for preeclampsia as well, interestingly enough. It is the leading cause of both maternal and perinatal morbidity, meaning complications that can occur during pregnancy. And there are higher incidences and severity among Black and Indigenous women. We know that with that, there are also disproportionately higher rates of maternal mortality. And many times these are influenced by social determinants of health, systemic racism, and risk factors. So higher rates of chronic conditions like high blood pressure, diabetes, obesity that could happen before pregnancy can unfortunately predispose these mothers from having preeclampsia during pregnancy. There also could be delays in diagnosis due to biases or dismissive care in healthcare. Oftentimes we call that medical gaslighting. There's also less access to quality prenatal care, often due to these structural barriers. And unfortunately, many of these women have fewer referrals to high-risk obstetricians or even cardio-obstetric experts like myself. And then we have to factor in the environmental and community level factors like food deserts, pollution, and unsafe housing. But as Lainey mentioned, it's not just the effects during the pregnancy, it's the long-term cardiovascular risk that preeclampsia unfortunately encounters, because women with a history of preeclampsia are 2 to 4 times more likely to have high blood pressure, ischemic heart disease, where they're at risk of having a heart attack or stroke, as well as heart failure, particularly heart failure where the heart function is preserved, but the muscle becomes stiffened, and you can be in and out of the hospital with episodes of shortness of breath or volume overload. We also know that this risk is not just during the pregnancy, as I referenced. It can be as early as 5 to 10 years after the delivery, but it could also last up to decades. We're now researching that even up to 40 decades after you were first diagnosed with preeclampsia, your risk of cardiovascular disease can remain. Preeclampsia is now, as a result of that, being recognized as an early warning sign when it comes to not necessarily just a pregnancy complication, but also an underlining or unmasked thing that can impact the inner lining of our blood vessels, increase inflammation, and cause vascular stress. And there are several reasons behind this, because when you think about preeclampsia, it's very much linked to cardiac disease in general. For one, they do share many of the same risk factors, such as obesity, insulin resistance, or issues with cholesterol. But we also know that once you have preeclampsia, there could be a potential lasting vascular injury where there's damage to that blood vessel because of the preeclampsia that again makes that vessel more vulnerable for heart disease in the future. And it's for this reason that we are thinking about preeclampsia as a unique risk factor for women. This is a very wonderful graph because it goes through all of the common risk factors that we think about when it comes to cardiac disease in women, the traditional ones like diabetes, hypertension, obesity, and smoking. They're definitely occurring in both sexes, but one thing I will say is that they disproportionately affect women more so than they do men. And then there are other unique risk factors that occur during different chapters of a female's life, be it when they first get their menstrual period or when they first go into menopause, or if they have any fertility challenges, or of course, complications during their pregnancy. And with 1 out of 5 pregnancies being impacted by adverse pregnancy outcomes, with preeclampsia and other high blood pressure disorders of pregnancy driving the way, it's extremely important that your physician and your providers are factoring this into their clinical history, and you're telling them that you encountered this so that way they can better determine how aggressive they should be in managing your other conditions. And why this is important for us as a cardiovascular society, us being the Association of Black Cardiologists and myself being a cardiologist, is that heart disease is a leading cause of maternal death. We know that when it comes to heart disease, this is just a graphic showing where the US stands in comparison to other first world countries, the US being at the very highest in terms of mortality. But then when you separate it by race, we see that Black women have the highest rates of mortality. And it's not just deaths, it's actually those near misses. So for every one maternal death, there are about 75 to 100 near misses, and Black women encounter the bulk of that, with preeclampsia being the leading cause. And this was really interesting data that the CDC released in February of this year, where although in all other race and ethnic groups, maternal mortality has declined from 2022 to 2023, there unfortunately was a steady increase in Black women. And I talked a little bit about the reasons behind that, but I do think it's important that we address the fact that a main component is that there is that higher prevalence of preeclampsia and chronic hypertension in women of color, particularly Black women. And again, it's compounded by that diagnostic and treatment bias, the less access to postpartum cardiac care, and the chronic stress and weathering that impacts that vascular health. So that vascular health is really the most important thing that leads to that cardiac issue. And Dr. Ansong and myself were very privileged to be authors on an article that we released with Dr. Michelle Albert, the former president of both the Association of Black Cardiologists and the American Heart Association, which talked a little bit about the weathering, a term we use called the biology of the superwoman schema. This is just a graphic adapting what we did, but what this really tells us is that the consistent discrimination and sexism that oftentimes women, particularly women of color, encounter, what does that actually do to their sympathetic nervous system and their inflammatory system? Well, the answer is it heightens it and it increases it. And there should be no surprise that as a result of that, many a times there's anxiety, depression, poor sleep, impaired immunity, and with that, cardiometabolic conditions like obesity, high cholesterol, high blood pressure. So all of this increased wear and tear on the body and exhaustion to the body does lead to that premature cognitive and cardiovascular condition. So there is a link between one's mental health and physical health, and that's extremely important when it comes to screening. And I wanted to talk a little bit about screening. So the American College of Obstetrics and Gynecology talks a little bit about what is recommended in that postpartum visit. Traditionally, the focus is on the immediate maternal recovery. They do emphasize mental health. They talk a lot about breastfeeding and contraception, but oftentimes there's an underassessment of that cardiometabolic risk factor. And this is where the American Heart Association, the American College of Obstetrics and Gynecology would like to revamp that immediate postpartum visit and make it more in line with the well woman visit. Because in the well woman visit, it is recommended that at least once a year, you're getting your blood pressure checked, you're getting cholesterol screening. If you're at risk of diabetes, that's being screened as well. You're being counseled on lifestyle modifications like diet, exercise, and weight management, but they're really honing in on your cardiac risk assessment, but using tools that consider your pregnancy history in the mix. But there are challenges that come with this. There are several. Number one is that there's poor continuity between the OBGYN and the primary or cardiovascular care team. We also know that when it comes to follow-up, there are underutilization, especially in those populations that have the highest rates, like the Black community, the indigenous population, or the low-income population. And we do need structures where it's easier to transition patients from their OBGYN to their primary care clinician. But there's also challenges because there's lack of providers being aware that conditions like preeclampsia can lead to long-term cardiovascular risk factors. But there are emerging models of care that are aiming to mitigate this. One is creating cardio-obstetrics programs. I've created one in my own health institution, and it's made the biggest difference in allowing that transition of care. We also know that when you think about this from the life course approach, it makes a big difference. You're going to be hearing from one of my colleagues, Dr. Annette Ansong, who's going to talk about how optimizing health, even during childhood, can best prepare us for future cardiovascular health. So extending care and including the pediatrician and the primary care doctor to monitor long-term impact, I do believe is going to make the biggest difference because it's going to lead to intergenerational health. Bringing in the community health worker is also going to be impactful as well. There's lots of data to support the impact that doulas have when it comes to pregnancy, but now we're actually thinking about the utilization of doulas even in that 1 year postpartum because there's lots of data to suggest that they're going to further impact in a positive way that care, particularly because they help to build the trust between the patient and their healthcare team. We know that remote blood pressure monitoring is another way, if it is covered, but also telehealth services is another way, also if it is covered. But integrating care really leads to reduction in loss to follow-up, and it leads to improved long-term outcomes. And I think that a lot of our strategies really focus a lot on lifestyle intervention. There is a role for medications as well, if needed, but there really is a role for patient education and culturally tailored programs. And I want to highlight one in particular because at the federal level, there are definitely a lot of policies in place. We have the Black Maternal Momnibus Act that is really lobbying to extend Medicare coverage and make sure that people are aware of these conditions that could impact women during their pregnancy, but also their future cardiovascular risk. I would like to highlight what the Association of Black Cardiologists has done, specifically because the ABC created a campaign called We Are the Faces of Black Maternal Health. And this campaign was really to highlight real stories that really provide a deep connection between maternal and cardiovascular health. It's sort of a call to action that all of us are accountable when it comes to the staggering statistics that we're seeing. On the website, you actually have fantastic infographics that help women navigate some of the challenges that they may face during their office visits because it helps them to know what questions to ask so they can advocate for themselves. I would highly encourage you to scan the QRS code and you can view our videos, but you could also view those infographics because this is a call to action. We really want to recognize that pregnancy is a risk factor and a risk marker when it comes to cardiac disease. We want to think about pregnancy as a window to future health, and we want to improve continuity from the OBGYN to the primary care doctor, but address disparities as well. And most importantly, empower patients and communities with education and advocacy. And I look forward to the Q&A. Thank you so much.
Thank you so much, Dr. Bond. We're now going to transition to Dr. Ansong.
I'm getting my slides squared away here. All right, do you all see that okay?
Yes.
Can you hear me? Okay, all right. All right. All right. Well, thank you, everyone. As Lainey said, I'm Annette Ansong. I'm a pediatric cardiologist in the Washington, D.C. area, and I was asked to come and be a part of this illustrious panel to give my perspective as a pediatric specialist on the maternal health crisis and along with preeclampsia. So I have no disclosures. And I'd like to begin with these three young women here. So you see Kyra Johnson, Shanice Wallace, and Amber Rose. So these were three women, three Black women who unfortunately succumbed to pregnancy-related complications and passed away. And as my colleague, Dr. Bond mentioned, Black women are 2 to 3 times more likely to succumb to pregnancy-related complications, which I'll go into a little bit more. So the number one cause of maternal death is cardiovascular disease. It accounts for over 400,000 deaths per year. And 84% of these deaths are preventable. And as I mentioned earlier, 2 to 3 times, Black women are 2 to 3 times more likely to die from pregnancy-related complications. Oh, sorry, I'm on a call. More likely to die from pregnancy-related complications than white women. So what are the reasons for this disparity? It includes implicit bias, structural racism, underlying chronic conditions such as diabetes and high blood pressure, variations in quality healthcare, and those social determinants of health. So Black maternal health disparities are so pervasive that they permeate nearly every step of the healthcare system. The cause is not limited to one area of medicine, but instead stems from shortcomings across the care continuum. So what does pediatrics have to do with it? So if you grew up in the 80s like I did, you knew Tina Turner. One of her major songs, "What's Love Got to Do with It?" So, as a pediatric specialist, what's my fight in this game? So, among Black women ages 20 years and older, near over half have some form of cardiovascular disease. So it begets the question, are there things along the way or specific to the pregnant woman that we can do to mitigate or lessen their risk factors for developing hypertensive diseases of pregnancy or other cardiovascular risk factors? So this has caused us in our committee, the Women and Children's Committee of the Association of Black Cardiologists, to sort of view things along the life span, starting from in utero to elderly women. Where along the way can we identify these risk factors and intervene? So before going ahead with that, I sort of want to look at the effects of preeclampsia in children, starting from the fetus to the young adult. So with the fetus and a mom who has preeclampsia, there's the risk of fetal loss and growth restriction. In the newborn, there's a risk of prematurity, and that has its own comorbidities, including and can include also death. In the young adult who is born to a mother of preeclampsia, you may see cerebral palsy, high blood pressure, later on in life, type 2 diabetes, or other forms of cardiovascular disease. So continuing on, the effects of the born child from a mother with preeclampsia include that these children can have high blood pressure and obesity, putting them at a higher risk for heart and or brain disease as they age. And close to 1/3 of young adults with high blood pressure were born to mothers of high blood pressure during pregnancy. So again, it begs the question, what can we do along the life course to intervene or mitigate these risk factors that lead to preeclampsia and or other cardiovascular disease? Because what we say in the Association of Black Cardiologists is that our Black mothers are first Black girls. So one of the biggest epidemics in pediatrics is the obesity epidemic. So this particular chart here sort of looks at obesity, breaking it down by race and by gender. And you see in children between the ages of 2 to 19 years of age, it's our Black girls that have the higher frequency of obesity. And unfortunately, this translates to adulthood, where you see it's the Black woman who have the higher frequency of obesity than other races and gender. So what can we do? So what we've done in ABC is to take the approach of educating the masses. So over the last couple of years, we have had different seminars and webinars looking at maternal health crisis as a whole, and then specific to different populations. This particular talk was one on childhood obesity, where we asked different specialists to come in and give an overview of the obesity epidemic, and then what solutions or what things could we do as a community to help lessen our children, becoming obese. And then also, it's engaging with the medical system, with our physicians and doctors. So one of the things that I've done, knowing what I know now, is when I take a history, I'll ask the parents or the more particular the moms, did you have preeclampsia when you were pregnant? Because knowing that their children are going to have a higher likelihood of hypertension and or obesity as well. Then there's the literature too, what's out there in the community, on the web, that we can use to help educate our colleagues, friends, and family. So the Association of Black Cardiologists, we have literature called 7 Steps to a Healthy Heart that sort of breaks down those things that we should do to lead a more heart healthy lifestyle. And it's really things that we already know, good diet, exercising, drinking water, things we've known all along, when we were younger, and just really being more mindful and intentional and implementing those habits into our daily lives so that we have better heart health as we get older. The American Heart Association also has Life's Essential 8, which is very similar to the 7 steps to a healthy heart. Then there's advocacy too. As you know, when I was growing up in the 80s, PE and recess was something you had all day, every day. But more recently, there's some districts and jurisdictions who are sort of decreasing or even getting rid of altogether PE and physical education. So that's certainly not good for our kids. And then in some of our schools, they have the soda machines and the snack machines and such. So just really being an advocate for heart healthiness, knowing that our children need more exercise, more fruits and vegetables, and less of the sugary material. And continuing along advocacy, as my colleague Dr. Bond mentioned, with ABC, we have had a campaign called We Are the Faces of Black Maternal Health, which provides a guide for physicians and for patients as to what questions they should be asking their healthcare provider, and making sure that during their pregnancy, all concerns and risk factors are addressed. CDC also had a program called Hear Her. Again, basically just sort of bringing to the forefront that we should always and at all times, listen to what the patients are saying. Then there's also turning this advocacy into legislation. So the Black Maternal Health Omnibus, which was spearheaded by members of Congress, and again, making sure that we optimize maternal health care and minimize the crisis. And this is just an infographic of what We Are the Black Faces of Black Maternal Health looks like. We have specific infographics for patients and specific for healthcare providers. But not also forgetting that, the research has to be at the forefront, because it's by, putting money towards maternal health and infant health that we can come up with good solutions to make sure that we mitigate the crisis. And with all this being said, it creates forever going generational health. Thank you for having me.
Thank you, Dr. Ansong. And now we're going to transition over to Dr. Hunter. And everyone, I forgot to say this at the beginning, but you guys are doing it anyway. Please don't hesitate to put questions in the chat. Our speakers are answering those as we go. So please throw that in there. We should have some time at the end to be able to connect. And Dr. Hunter, you're still muted, just FYI.
Sorry about that. I had technical issues clicking the unmute button.
You are totally fine. Go for it.
So my name's Christian Hunter. I work for Abbott Laboratories, and I'm a full-time employee of them and shareholder. I'd like to talk a little bit more. I got so interested in these previous presentations, I actually forgot I was going to talk next. So this is such good information, and it's wonderful to be invited to be part of this. I'd like to give some global perspective on cardiovascular disease in general, and specifically how in low and middle income countries these problems of preeclampsia and pregnancy-related hypertensive disorders are both affecting women, and how community groups and providers are working together with governments and other advocacy organizations to mitigate the harm from this condition. So I worked and practiced in Southern Africa and Namibia, and throughout the rest of Africa for about 14 years, where I was the head of the Department of Medicine at the University of Namibia's fledgling medical school, and practiced and taught clinical medicine in their large teaching hospital, and in throughout the country where we implemented programmatic healthcare. As part of this practice, I provided consultative advice to the maternal critical care unit and to the labor and delivery units from a cardiology and internal medicine perspective. And in that role, I also provided advice and care in distributed environments throughout the continent where we would go into clinics and community centers. And what I've learned there and around both the delivery of care and about the distribution of risk factors for cardiovascular disease is that we have seen real improvements in these, and particularly around maternal mortality around pregnancy and in the time after pregnancy. And much of this has been done through improvements in the delivery of care, the attendance of care, prenatal care, but also the treatment of infectious disease. The HIV programs that have been launched, malaria, TB, have all contributed to reductions in mortality, along with improvements in the pharmacology of hemorrhage control, so reducing bleeding in pregnancy, and and reductions of unsafe pregnancies. However, cardiovascular disease, as women are surviving and they are healthier from infectious disease and from traumatic bleeding, we find that there are still very high rates of cardiovascular disease. And if we look at these colors on the map here, the darker reds are showing higher prevalence of cardiovascular disease than in the lighter, cooler blue areas. And what we see looking across this map is that in many of the high and middle income countries, there have been reductions in cardiovascular disease, although it still remains the number one killer or the one cause of death. There have been major reductions. There have been reductions in some other areas, but this lags alongside of the financial resources that are available in these countries. And along with cardiovascular disease, we can see that the risk factors well, let me first show about some of the reductions in cardiovascular death rate globally across the world in both men and women. So while we've seen a global reduction in cardiovascular disease, it still remains the number one killer of humans and a significant burden for women in pregnancy. And yes, so the risk factors for cardiovascular disease, which have been touched on, they both include modifiable risk factors and non-modifiable. The non-modifiable perhaps maybe our genetic history or your age or your gender, but your cholesterol, your glucose levels, your body mass index, and tobacco use in physical activity, as well as raised blood pressure, are modifiable risk factors. We've mentioned that obesity has become an important risk factor in high and middle income countries, but we're seeing now with the availability of unhealthy food types and processed food and what I would consider a westernized diet and the change in globalization, that we've seen an increase in the amount of obesity and diabetes throughout low and middle income countries as well. And this is expected to increase, not decrease, as going forward, unfortunately, and is leading to increased risks around pregnancy related as well as cardiovascular in general. Raised blood pressure, it confers a high risk both in and around pregnancy, and as well as global lifetime risk. Diabetes as well, which is elevated blood sugar and dysregulation of both your insulin regulatory systems and in our diet, lead to increased risks around pregnancy-related complications, both during pregnancy, around pregnancy, and after pregnancy. So as we've seen that these cardiovascular risk factors cause cardiovascular disease, we are now understanding that preeclampsia and other hypertensive related disorders confer lifetime risks that go on past the initial insult that it happens in pregnancy. And as we are struggling in the low and middle income countries to be able to implement this into care, we've identified some factors that have been barriers to this care. And this, I would say from my own practice, not even looking at data, it would be a lack of coordination and communication between teams, which I think we all recognize just in our regular lives. Whenever that drops out in any activities we're doing, we move into a low functioning environment. And unfortunately, in healthcare, we often could be siloed. And so what I often would see is women that would develop a condition in pregnancy, like hypertension, preeclampsia or eclampsia, receive treatment, and then afterwards be lost to care until later they would be admitted to my service or to another service with significant shortness of breath, signs of heart failure, and other cardiovascular complications. So seeing that there increased care there and seeing implementation of communication pathways between our professional teams and forgetting that, like, for instance, I just take care of the heart and my colleague takes care of the mother during pregnancy and afterwards, and instead looking across continuity care around common risk factors is a much more holistic way for us to operate. And we see throughout low and middle income countries, I've seen this myself, and it's been studied that there's very community perception around this condition, meaning that there is a lack of education, a lack of understanding, and honestly, a lack of perceived importance where they thought, oh, this is just a pregnancy related complication. After that, we don't really have to think about it. And so this very community perception where we've seen that without that, we can't move forward. And when it comes to HIV, we've seen tremendous input from the community, alignment there, and that's which has really driven a lot of the changes in care. A lack of validated guidelines. Many of these countries are going off of guidelines that were developed in other regions. Lack of surveillance, difficulty in implementing prediction and prevention strategies. So while we've seen improvements in biomarkers or lab tests and other tests that can both predict some risk of developing preeclampsia, as well as measurement of and detection of heart disease, unless we implement these in a coherent strategy, then we won't see improvements in care. So some of the activities that I've seen be useful in these regions where you're working with very few resources, or education and empowerment of healthcare personnel and patients. So many doctors still do not have the education that we need to be able to work in a coherent way. We're still perhaps only thinking about the things that we were trained in or that our mentors emphasized rather than that are important to women in pregnancy. We need that government investment in public health initiatives. And I think now more than ever, and I think many of us consider it under threat. And all of this is just part of a small, opportunity to be able to improve maternal and perinatal outcomes. I'd like to end by just focusing on the fact that while we often think of our own environment and our own communities, and it is really important for us to advocate within those environments and communities, for us to be able to strengthen our communities where we live, we need to be aware of the communities that are outside of our networks. And strengthening, internally will only have a micro change, where if we understand communities that are outside of our own, that are concerned about this, and in different countries and in different cultures, then we can scale this problem, scale solutions. Because right now, the majority of the work going into this is as high and middle income countries. And while we're happy to see improvements there, although improvement is slow, it should not be restricted based on the financial class that your country remains in. So I'd like to encourage us all to, celebrate the improvements we've made, but also make sure that these are equitably distributed throughout the world for people in need. Thank you very much.
Thank you, Dr. Hunter. That was such good commentary and an important perspective, because as you shared, a lot of the maternal mortality and morbidity that happens because of this disease does happen in low and middle income countries. So I, unfortunately, Selena Gore was not able to join us this evening. So I actually would love for us to be able to address some of the questions that our participants and audience had in the meeting chat, which Dr. Bond was doing a fantastic job of answering as much as she possibly could. But I would like to at least float out some of the ones that maybe don't have specific answers. And please feel free. We may not be able to get to all of these, but one of the things that is always so helpful to the Preeclampsia Foundation team is for you to go ahead and put your questions out there, because it may be that we can call upon some of the experts like those we have here, as well as others that are part of our community, to answer those questions along the way via articles, social media content, and other things. So we don't want to leave you hanging. We always want to make sure that you get the information that you need. Just going to go back to the beginning. So we had one patient who asked, do you think undetected rheumatic heart disease from untreated rheumatoid fever could be a cause of HELLP syndrome? Anyone interested in taking that one?
Oh, can you hear me?
Yeah, I can hear you now.
Oh, okay, perfect. I will say that that's a really thoughtful question, and we appreciate you asking that question. And I think while rheumatic heart disease and HELLP syndrome, they both, we know, can affect the cardiovascular system. We just don't have any data or research right now that demonstrates that there is an established link. That doesn't imply that there's not. It just means we need more research. And we know that this is an area that we definitely do have to research. I think in theory, when it comes to just the impact that HELLP syndrome and these hypertensive disorders of pregnancy are having, like I suggested, it's at that inner lining level of the vessel, or what we call the endothelium. And yes, conditions like rheumatic heart disease could affect that as well. So although there is a link, we just don't necessarily have enough research to demonstrate that it's probably a causal thing. But for that scenario, it would be recommended that you are under the care of a heart specialist, a cardiologist, who's keeping an eye on your valvular condition, because that's one thing that we worry about with rheumatic heart disease. And then especially if you had preeclampsia with that as well, they're just doing their due diligence and better preparing you on how to lower your risk of having any issues in the future. So that's what my suggestion would be, that both conditions do deserve close monitoring, especially in high-risk pregnancies. But right now, there's not necessarily a link between either of them.
Yeah, and I think in general, just as a sort of like 30,000-foot view, there were a lot of questions in the chat about various conditions and how they might relate to preeclampsia and HELLP syndrome. And to Dr. Bond's point, the data just isn't there yet. We're doing a better with women's health research in general, but ways that you can also contribute to that is by doing things like participating in the preeclampsia registry, where we do work with researchers to look at some of these important questions about autoimmune conditions, or different types of heart disease, or different types of maybe other conditions that might impact pregnancy health and how it might relate to it. So that's just my little plug to say that all of us can actually contribute to the research. We had another question that says, can you speak to the impact of alcohol on cardiovascular health?
I think this question, along with the other questions around associated conditions, have a related answer. And what Dr. Bond said, I agree with wholeheartedly. I've taken care of a lot of women with rheumatic heart disease who are pregnant. I've taken care of a lot of women who have abused alcohol who are pregnant, people who haven't taken care of their weight or other, their diabetes. And what we see is that your health should be optimized as much as possible. And we know that any exposure to alcohol can be dangerous. And, there's definitely reductions in alcohol exposure have improved health outcomes. Whether it's directly related, it may be, but it's hard to tell. But I would encourage everybody with these health behaviors that we know, everything that we can tune up, we should tune up.
Yeah, and that's, the sort of message of hope that we leave everyone with is that there's nothing that you can do about your preeclampsia or HELLP syndrome experience. You went through it, it happened. But those modifiable risk factors, like making sure that your cholesterol is in check, making sure that you're going to a well woman visit every year, making sure that all your CBC, your blood numbers are in a good place, that your blood pressure is controlled, that you're eating a good healthy diet and getting some cardiovascular exercise. Those are all things that we can control and that are small steps. And I really love trying to think of what the name of the book is, but it's about, sort of the power of small behavioral changes. But it's really a great metaphor for the fact that for preeclampsia survivors, those small changes are even more important than they might be to a person who had a normotensive pregnancy.
If I may interject about the question about alcohol.
Yes, of course, Dr. Fletcher, go ahead.
Dr. Anthony Fletcher, president of ABC. First of all, excellent session, very informative, and very proud of the presenters in terms of thoroughly discussing the topic. But to address directly the issue of alcohol, whether it's pregnancy, preeclampsia, and or just general cardiovascular health, alcohol can be a toxin to the heart itself. It's a substance that can affect the strength of the heart, making it weak and therefore more likely to be proposed or disposed to heart failure and or cardiomyopathy. It also can affect your heart rhythm, perhaps potentially propagating atrial fibrillation. And then thirdly, it also contributes to hypertension. So those are three reasons that one should abstain from alcohol, especially during pregnancy, but overall in terms of large quantities of alcohol, even in general health, postpartum, prepartum, all of those should be considered in terms of watching your alcohol history.
Yeah, that's such a great point, and thank you for hopping on and speaking to it, Dr. Fletcher, because that understanding the full constellation of what the patient has experienced in life, we know is critical to optimizing the health. We have time for about two more questions. We had a person who asked, if a patient only had high blood pressure during pregnancy and then 35 years later gets AFib and heart failure, heart muscle got very weak, cholesterol and everything was always good, is her preeclampsia really impacting the heart muscle decades later?
Yes, it's very possible. Like I had stated, what happens during pregnancy can impact us up to several decades later. So it is possible that her history of high blood pressure during her pregnancy, likely preeclampsia, contributed. Unfortunately, many of these women are at 2 to 4 times greater risk of having either atrial fibrillation or a weakened heart muscle. So this is why understanding your history, your full history, including what happens during the pregnancy, is so impactful because it helps us as physicians to better understand how we should manage you, but also even for your future children. Dr. Ansong did an amazing job in highlighting some of the effects that preeclampsia can pose also on the offspring. And I think for her, even as a pediatrician, she, as she mentioned, is just reinforcing and changing how she even asks questions when it comes to pregnancy history, because now it's helping her to make sure she's focusing a little bit more as she sees the children in their visit on things that they can do to lower their risk if they do decide to have their own children in the future, or even for their own cardiovascular health. So preeclampsia can follow us till several decades later. We're realizing now it could be on average even up to 40 years after, so up to 4 decades later. And again, that this is a growing area of research, so we're continuing to learn more and more about it, but your pregnancy history does impact your future cardiac history.
Definitely. And that's actually a good transition to the next question, which I think Dr. Ansong could probably speak a little bit to, but the person asked, my daughter whom I had preeclampsia with, should my daughter whom I had preeclampsia with tell her primary care doc that I had it, even if she doesn't plan to be pregnant. And my other daughter who does plan to be pregnant, should she tell both her primary care and her OBGYN?
Yeah, so absolutely for the 23-year-old daughter, as I mentioned in my presentation, those children born to mothers that were preeclamptic have a higher likelihood of hypertension, and can also have a likelihood of obesity. So as a primary care physician, that's information that they should have, so that when they see these patients, they can pay a closer look at their blood pressure and other vital signs to make sure there are no risk factors for cardiovascular disease.
Yeah, definitely. And I think just in general, modeling those healthy lifestyle behavioral changes and things that we can do. Again, the factors that we can control, we can't do anything about our risks, but we can do something about the controllable factors.
On a positive note, though, around our risk, I think many of us, if we've told that we have a higher risk for something in the future, right? That can be a scary feeling for us because we feel that, oh, I've been sentenced to this. That is not the case. What it does is it gives us tools that many of us wish we had because we all have risk of things that we don't know. And we've seen such amazing advancements in the early diagnosis of heart failure. We've learned to better seek out and treat hypertension, that the effects of this predisposing condition can be mitigated through early prevention. So identification of dysregulated systems. Is your blood pressure high? Are you starting to get heavier than you should be? Are you eating too much sugar? And then blocking these things down. And if we do develop heart failure, we want to catch it early because we can bring people back to a high functional state. We just need helps of the patients. Doctors need to listen to the patients as well.
Yeah, definitely. That's such a good point. Just waiting to see if there's any further questions. So someone also asked, do the same risks apply to children of mothers who develop postpartum preeclampsia? So this question was asked by a couple of different people, and I'll just say that what we understand about postpartum preeclampsia, specifically new onset, so that's a patient who was normotensive through their pregnancy, didn't seem to have any complications, and then after delivery developed high blood pressure. What we understand at this point about that is that it looks a lot like late onset preeclampsia and maybe actually due to those placental factors that are flowing through the bloodstream during pregnancy, and it just doesn't quite tip over the edge into a disease state until after delivery. There's also, I think somebody mentioned it in their presentation, there's some shifts in blood pressure, some natural shifts in blood pressure in the postpartum period that can cause an increase in blood pressure postpartum. So I'd love Dr. Bond to just talk a little bit about that.
Yeah, so postpartum preeclampsia is also an area that we are researching. And, one insightful point that I think we in the cardio-obstetrics world is thinking about is why are we seeing higher rates of postpartum preeclampsia? I think one thing, which again is just a theory, and with a theory comes research and we have to prove it, but it's because we think that with the utilization of aspirin, which does do a fantastic job in helping to reduce at least early and severe preeclampsia, once the aspirin is discontinued, we don't have that protection anymore. So one thing that we're doing on our end is to determining is there benefits in extending it to up to that 6-week postpartum window. That also implies that aspirin is clearly effective in what the intent was, which is that we get the mother to the lowest risk possible, understanding that we cannot entirely reduce preeclampsia. And aspirin is helpful because, again, at the vessel level or the vascular level, there's inflammation there. It's helping to regulate that, and it's helping to really relax the vessels. And it's really at the placental level that it's doing that. And as such, most people who are at heightened risk for preeclampsia, either be it moderate risk or high risk, and that could be easily calculated by your OBGYN or high risk OBGYN, like a maternal fetal medicine expert, they are recommended to start aspirin at 12 weeks gestation prior definitely to 16 weeks gestation, but even up to 28 weeks gestation, you can start aspirin. But the earlier you start it, the better if you are at a higher risk of preeclampsia. And then other factors also that help to reduce that include, again, having some input from your primary OBGYN team is making sure that you're exercising throughout the pregnancy. And there's a lot of research to also support sometimes an anti-inflammatory diet, like a Mediterranean diet, which we normally recommend for cardiovascular health throughout the pregnancy, can also lower your risk of preeclampsia too. So I'm just excited that we're actually talking about a condition that is impacting one out of 5 pregnancies and also impacting one's future cardiovascular risk. And I think that the more other specialists talk about it, including cardiologists, moving it beyond just OBGYNs, then we're going to actually research it more and figure out how best to manage patients both during their pregnancy, their early postpartum, and their post-childbearing age as well.
Definitely. So we are at time, everyone. We appreciate all the great questions and all the great feedback. We have recorded this presentation, so we will send out that recording, especially for those who have trouble joining. I apologize for the technical difficulties that we were experiencing. So those who joined late, we will have that recording to send out to you early tomorrow morning. And I just want to say thank you again to our fantastic presenters. I am always so honored to work with you all, and we look forward to the next webinar that we're all on together. Thanks, everyone.